Good evening. I'm Dorothy Tucker, President of the National Association of Black Journalists. Thank you so much for joining us this evening for this very special town hall. The American Medical Association and NABJ have partnered this evening to take a look at the impact of COVID-19 on the Black community. This is a wide-ranging discussion that will touch on how the pandemic, again, is impacting our community, health equity, as well as the importance of science, data, testing, and a lot more. Joining me tonight on behalf of AMA is Dr. Patrice Harris, the president of AMA. She is the first African-American woman to be elected to the American Medical Association. Good evening, Dr. Harris. Thank you so much for joining us.
Good evening, Dorothy. Thank you so much for having me. I will tell you that the American Medical Association is so honored to partner with NABJ as we have this critical conversation.
Well, we have a lot to talk about, and we would like to start off first, allowing you to give us some opening statements before we have lots of questions.
Very good, very good. Well, again, thank you so much. And to state the obvious, the coronavirus pandemic is presenting a challenge to us that we have not seen in this country for generations. And, you know, it will take months, maybe years, to fully understand the impact on our nation and on our population. But what is already clear, and I'm sure already clear to many in your audience, is this pandemic is having a disproportionate impact on African Americans. Certainly several weeks ago, data first started to come out from Milwaukee, from Chicago, from Washington, D.C., about the disproportionate impact on African Americans. And just yesterday, we received a report of a study, not been published, but AMFAR, that is looking at county level data, which I'm sure we will get into a little later when we talk about the importance of data, and further shows the disproportionate impact on African Americans. So it is very important for us to have this conversation. You know, I said in other venues that I spent the first couple of weeks of this pandemic, not in my professional role as president of the AMA, but in my personal role as a family member and friend, dispelling some of the many myths that were out there, particularly around the African American community. I had to say multiple times that yes, African Americans can become infected with COVID. So it again is very important that we combat misinformation and disinformation. And again, because every day we are learning about the disproportionate impact of COVID-19 on our community, on our nation at large, but particularly on the African American community. And so why? A lot of conversation in the media about why. And I like to look at it sort of in three big buckets. The first is the pre-existing condition, if you will, of diabetes and hypertension and obesity, some of the illnesses that, again, we all know disproportionately impact the African American community. The second issue is around the workforce. We've seen, and we still need data on this, and we certainly need to get more data on the workforce, but certainly in those frontline essential jobs, and certainly not just in the health profession, but those folks who are what? Driving our buses, right? Driving the trains, cleaning our facilities are overrepresented, if you will, a large proportion from those communities of color. And then we have to talk about structural inequities, not always an easy conversation to have, but conversation that we must have. Of course, I always say if you come to the conversation to talk about structural inequities and the structural determinants of health inequities, you have to make sure you come armed with information, right, and education. But we know implicit bias and discrimination, housing inequities, living in dense areas, and why that is happening. All of those are contributing to where we are today regarding COVID-19. We have to have conversations about structural racism, not always an easy conversation to have, but an important conversation to have. And I have to say, and we can talk more about this, but I'm very proud of the work of the American Medical Association. And about a couple of years ago, we established our new Center for Health Equity at the AMA and hired our first Chief Health Equity Officer, Dr. Aletha Maybank. So we are committed to having these conversations right now. But more importantly, and we will need NABJ to continue to partner with us on that, we need to have these conversations post-pandemic, right? Because we will need to address solutions. We have the data right now, but we certainly need to discuss and act on solutions. We need to make sure we look at issues around affordable housing and food deserts. You know, I used to say that it's very easy for me to tell my patients to increase their activity. And I might say, you could just walk around your neighborhood, but if there are no well-lit sidewalks, right? If, you know, people might not even be able to do that. So these are all the conversations that we need to continue to have. We certainly are ready to lead on those conversations at the AMA, and again, look forward to continuing work with the NABJ. I have to just put a final point on two big things in this pandemic. We must always make sure we are combating misinformation and disinformation. I talked to you at the beginning about the myths and the rumors that were out there. And unfortunately, there continues to be misinformation and disinformation. We have to be grounded and rooted in the science and the evidence and the data. And decisions around this pandemic have to be data-driven decisions. And at the AMA, we are committed to rooting out bad science, actually not really science when we see it. We have to hold everyone accountable, our elected officials, our tech platforms who host social media. So this is something that, again, we need to make sure we are committed to working on, and that is rooting out the information, the disinformation and the misinformation that is out there. I want to just finally say, as everyone knows, we don't have a cure for COVID-19. We don't have effective treatments as of yet. Science is progressing as we know and as we speak, and we don't yet have a vaccine. What we do have right now are the basic tenets of public health. We have to make sure we are physical distancing. I like to use that term because I want to make sure we maintain social connectedness, right? And so we still have to make sure we do not gather in large groups, that we wash our hands, that we wear face coverings, and that we stay at home, that we shelter safely at home. It saves lives. We know it. It seems simple. Some people say it's too simple to even be rooted in science, but it is. And if each of us makes our individual actions result in collective impact, we will go a long way in spreading the course of COVID-19. So again, thank you for allowing me a few minutes of opening remarks. I look forward to the conversation tonight, and thank you again, NABJ.
All right. Yeah, I know we're going to have a good conversation. You touched on a lot of different topics. One of the things that struck me, you talked about the misinformation, the disinformation. So in your opinion, where do you think journalists are making their biggest mistakes in covering this pandemic?
Well, you know, I think journalists actually are doing a great job overall, asking questions, challenging assumptions. And I think we just need to make sure we continue to have conversations around and set the stage for conversations around all of these issues. Health inequities, mental health is another issue I'm sure we will get to. I realize that in a quick sound bite, and I've been able to be on the media a bit, making sure that we get good information out there. It's difficult, but I think the media should continue to ask the hard questions. When a new study comes out, it's important that we recognize it's an early study, and we are all tired and we want to get on the other side. But as studies come out, we have to temper our excitement and enthusiasm, and we have to wait for the science to play out. But I think journalists are doing a great job of asking hard questions and challenging, and I say this of everyone, challenging assumptions.
It's difficult to ask the right questions when the medical professionals seem not to agree on everything. They have different answers for everything. So, how are we supposed to deal with that? And the doctors themselves, how is it that there is so much disagreement, so much conflicting information? And we know this is something obviously we've never dealt with before. This is something that is changing, but it does make our jobs much more difficult when it changes sometimes by the hour. And I wonder, the medical profession seems to be struggling just as much as everybody else, obviously.
So I would say a couple of things, and I will say, first of all, let's just assume, because we know that there are sources of information out there that are not credible. So let's put them to the side and let's talk about those physicians and scientists and researchers who are credible. So I might say, Dorothy, it's not conflicting information necessarily, but I will give you the point that it is changing. It is ever changing. And actually, thank you so much for bringing that up, because I know that that can be frustrating. But you have to internalize that and I guess integrate the fact that research and studies are happening every day. And we will learn new information every day, and we will evolve. And so I would say, I'll give you a case in point. At the very beginning of this pandemic, most of us, myself included, and other very respected physicians and other scientists, we were not encouraging folks to wear masks.
Exactly. I was going to use that as an example.
When we
right
learn,
now,
yes,
everybody's wearing masks.
yes,
So.
and I would say that's we learned more about the virus, and so we did make that recommendation. And let me just say something my grandmother used to say. Didn't have any formal education, but she was a wise woman, and she said, when you know better, you do better. So I would say it's not conflicting, but it's changing. And we should be transparent about the fact that it's changing. We should be transparent about the reasons why a new particular piece of advice is changing, and then go from there. So everyone should expect that the information does change. And I would say that's a good thing, because that means people are accepting the new evidence as it arrives.
It's a good thing that it's evolving, but I have to tell you, I think it's very frustrating for the American public, very frustrating for people who are trying to figure out just how to cope. And I'll tell you from personal experience, as someone who tested positive, initially, I get the test results back and I hear from my doctor and she says, okay, you've got to quarantine for another 14 days. Well, I just quarantined for 14 days. And then I hear from the health department, they call me the day after, and they say, okay, you quarantine for 7 days. And then I hear from someone after that and say, oh, nope, 3 days is fine. So people are really in a tizzy here. So, my question is, where do the doctors get their information from? You get it from the task force when the president presents a news conference? Is there another location, area that they get it from? How do doctors know how to tell patients?
So it's based on the data that as I said, a new study might come out that day. And say, listen, we have new information from X studies. And of course, by the way, credible sources of information will only use studies that they believe are credible, peer-reviewed studies. That's sort of the lingo of the profession. And so I would encourage folks to find one or two credible sources of information and keep going back to those credible sources of information. And I would say the AMA is a credible source of information. We have a website now. I will say that we update our website. When we get new credible information, we put it on our website. Our website is mainly physician focused, but I urge everyone in the public to pick one or two credible sources of information and stay with them. But we do get our information by keeping up with the literature, and this is not new. This was our usual state of being before COVID-19. We have to keep up with the literature or read the latest studies. But in a fast-moving A pandemic like this, everyone has to expect that the data will change. And I'll say one more thing about, and I don't like to speak about personal situations, but I do encourage everyone to stay connected with their usual source of care, because what may be needed for you individually based on your health history, based on where you live, might be different. And that's why I think local, so stay in touch with your usual source, and your physician is giving you information based on your individual health needs, which might be different than me because my health needs might be different. So pick one or two, stay closely connected with your usual source of care.
Okay, let's talk about the antibodies, the blood tests that are out. Again, like the information, there are so many tests out there. The FDA seems to have approved a number of them, but then I understand they're beginning to take a second look at some of them. What do you know about those blood tests? What do they test? And, ultimately, what should the public be looking for?
So big picture, there are two types of tests. There's the diagnostic test. Most people are familiar and have seen or heard about the nasal swab test. That there was a swab goes in your nose to the back of your throat. That diagnostic test tells you whether or not you have an active infection, whether or not you have COVID-19. And by the way, let me just say this, I'm sure the audience may know. The name of the virus is the novel coronavirus, SARS-CoV-2. Coronaviruses are not new as a family, but this particular coronavirus is new. That's an important marker to set at the very beginning. And so it's the novel SARS-CoV-2 coronavirus that is causing COVID-19, which is primarily a respiratory illness, but as we're learning more, it can cause other problems, clotting and so forth, and so on. So that I wanted to give a little bit of that background. So there's the diagnostic test. Are you actively infected with the disease? Then there's the antibody test, right? So antibodies are the blood components or that in our body, not blood components, that fight an infection once we have an infection. And so an antibody test will tell you if you've already had the infection, right? And that is, you have to get that either through your vein, a blood draw, or a finger stick. Now, you're right, the FDA, Federal Food and Drug Administration, has the responsibility of approving the test. The last I checked the website, although this is ongoing, there are, I believe, hundreds of tests on the market.
Like 150 or something
Yes,
like that
yes.
that are out there.
But the last I checked, I believe the FDA has approved 12. And so what we want to do, and what we encourage everyone to do, and actually the American Medical Association sent a letter saying that we wanted there to be clear guidance, because we know, I'm a physician, so I keep up with this on a day-to-day basis, but people need to know which tests, right, have been approved, and which tests have not been approved by the FDA. So we did ask for guidance on that. Our current recommendation is, if you receive an antibody test, talk to your physician, take those results. If you don't get it, through the hospital, take those results to your physician and talk about the test, where you got it, who did the test, and let your physician help you look at those results, because antibody tests tell you one thing. They tell you that you've had the infection. We don't know yet about immunity to the novel coronavirus. We don't have that data yet.
Okay, but where do you find out about these 12 that have been approved from the FDA? Is that on the CDC website? Is it on the AMA website?
It is on the FDA website, and they will continually update that, because again, I checked and it was 12. They may in the last 15 minutes have approved more, so I would go to the FDA website. And we did ask the FDA to be really, to offer clearer guidance to the public. I mean, I rooted around the website and I can find it, but we did ask for specific, here are the tests that have been approved, and these have not yet gone through FDA approval.
To our audience, I find myself looking and seeing your questions here. Give me a couple more minutes, and I promise you I will get to your questions, because you've got some great questions here. But I have to make sure that I ask Dr. Harris a couple of more questions, and one that I know all of our members want to know. How do you rate President Trump and the way he is handling the pandemic, and what could he have done differently, in your opinion?
Well, certainly from my personal vantage point and from the AMA's vantage point, we stay out of the politics. For us, it's all about health and science. This is a public health issue, crisis, and it requires a public health focus. And so we want to stay out of the politics. We want to make sure that the science and the evidence leads our discussion through this and leads any solutions to this.
All right, so what does the science and the evidence tell you about whether we should reopen?
So this is very important, and as you know, each state and each region is approaching this a bit differently, and actually that's not necessarily a bad thing. There are some hot spots in this country that may need a different priority. I will say the original recommendations that came out of the task force were good recommendations. They recommended 14 days of sustained decrease in the number of cases, the number of syndromic illnesses. They certainly recommended having a robust testing infrastructure. And by the way, that doesn't just mean having this test. It means once you find a positive, you have to have the ability to track and trace everyone that's been in contact with the person who's tested positive. And another piece of that puzzle that we need to talk about more is the isolation. You talked about being quarantined or the need to isolate for 14 days. What if you don't have the privilege, right? What if you live in a multi-generational home and you don't have multiple bedrooms? And so we know that some local jurisdictions are coming up with creative ways to support isolation, such as using unused hotel rooms, unused dorms. So public health tells us that, first of all, it is a false choice between the economy and health. They are interwoven, and the data in your particular locale should drive decisions about what and when to open. And of course, you can have a measured approach. You need metrics. You need the ability to, once you see your case numbers go up, to pull back. And I will say one final thing on
Dr.
that.
Harris.
Yes, let me say one final thing on that. Something that needs to, or a phase that needs to open up early, are physician practices. Physician practices have reduced hours or shut hours down, postponed elective surgeries, but we need to make sure that our patients, from the AMA standpoint, get the care that they need. So certainly any early measures regarding opening up needs to make sure the health ecosystem is taken into account.
But aren't you at all concerned that if we open up too early, that we're going to see a resurgence of cases? And given the fact that African Americans are disproportionately affected, that's going to mean particularly more deaths in the African American community. So how can you say that, measured or not, that it's a good thing to begin to open up?
Well, I didn't say it was a good thing.
Okay, so give me your personal opinion.
I said that decisions regarding loosening restrictions need to be made based on the data, and they need to be based on the local data. And there is no one-size-fits-all approach here.
So where would you say we shouldn't open it? What cities would you say, no, don't, they should not open?
And open up, what does that mean? Open up what? And so I would say...
Well, that means essential businesses began to open.
Yes.
That means beaches. That means barbershops and salons, which again, of course,
yes,
we go back to the African American community where, the numbers are higher and stuff. That's what that means. That means restaurants.
And so each one of those might have a different measure. Let me just take beaches, for example. Let's say there's an area where there's not a lot of disease. on a beach, you are outside. So again, and I realize folks want sort of a one size fits all, yes, but it's much more nuanced than that.
Okay.
We want people to go outside, and so perhaps in an area where they've seen decreased testing, if folks are outside, if folks are wearing a face covering, I want to say that, doesn't have to be a mask, if folks stay 6 feet apart on all sides, and if folks are continuously moving, that is not is not necessarily a bad thing. That can be a good thing. So again, there are no hard and fast one size fits all answers, but certainly everyone at the very minimum, as each jurisdiction and each locale decides to open up, at the very minimum, everyone should wear a face covering. No one should be in a large gathering. Everyone should be 6 feet apart.
So speaking of face covering, speaking of masks, speaking of Black folks who are concerned about wearing masks and the incidents we've seen, the stories we've seen about Blacks being pulled over and being arrested and being accosted because of the masks, what do you say to that? And, I mean, this is something that community is dealing with.
A conversation that we have to have here in Georgia, and I might not have the specific law, but there was a law against face covering, and our mayor, had to raise the level of awareness about that during this time of pandemic, because it is critical to wear a face covering. Face coverings protect others, not necessarily you, but protect others. So you bring up those nuances in communities of color that we have to have a conversation about and have to confront. We still have to wear a mask, a face covering.
And you mentioned before all the various inequities, the disparities in health and access to food deserts and such. What is it going to look like on the other side of this pandemic? What solutions can we put in place to make sure that those issues are addressed that are now being highlighted?
We are certainly going to have to address access to health care. As you may know, and your audience may know, the American Medical Association supported the Affordable Care Act. We supported Medicaid expansion. We certainly support strong safety net health programs. So we are going to have conversations about that. The AMA can and has and will continue to advocate for that. We are going to have conversations, but I will say this is where partnerships come into play. We will have to have city planners and those who are looking at transportation, those who are looking at housing and affordable housing options. So we're certainly going to need our elected officials, industry, public-private partnerships to come together to address these issues. And again, I'm very excited that Dr. Aletha Maybank and the AMA Center for Health Equity will lead that discussion, but that's going to require an all-in effort. But let me give you an example of something that the AMA has already done in Chicago. Now, the AMA, of course, is a national organization, but we wanted to partner. Of course, we are based in Chicago, and we wanted to partner on a pilot project with a group in the west side of Chicago. So we have made a financial investment to a group, and there are universities involved in that. Again, academic institutions need to be involved in it, but we have made a financial commitment to invest in that community. But you know what? Who's going to drive it? Not the AMA, the community. The community has to have a seat at the table. The community needs to say, this is what we need. And the AMA and other partners, Rush in Chicago, are joining together, working with the community to address their needs. And that's the other piece. These decisions need to be community-based and certainly need to have the community voice.
Speaking of the community, how are people coping? As a psychiatrist, what are you seeing?
Well, I would say, in addition, there are so many things that this pandemic is uncovering for some, amplifying for others. We've already talked about health inequities. The other is mental health. And the other is public health, so many. But our mental health system has been woefully underfunded for decades. Of course, as a psychiatrist, I'm particularly attuned to that. And so we are going to have a conversation about mental health in this country. Now, certainly everyone is experiencing, well, not necessarily everyone, but we know fear and anxiety and worry are normal human emotions, and a lot of folks are experiencing those. Listen, routines have been disrupted, graduations, birthdays, all of that has been missed. And so those are normal human emotions that we can all expect. And then we have those who already had a diagnosis prior to COVID-19. And we know local jurisdictions, physicians, psychiatrists, the mental health communities pulling together. Telehealth is something I'll just quickly say that a lot of physicians in general are using to make sure we maintain access to care. That's using a video or even using the telephone to stay connected. It's not a panacea, not for everything, but that's one way. And that's a way we have been able to, as psychiatrists and psychologists and other mental health professionals, to stay connected during this time. General coping skills, I encourage everyone, first of all, to allow yourselves to feel what you're feeling, to be frustrated. You don't have to say, you know, I need to be perfect. You don't have to not feel frustrated that you're trying to work and you don't have childcare, you don't have school. We need to ask for help. We should try to get as much sleep as we can. And we need to move. And I mentioned exercise and the importance of getting out, but getting out in a safe way. But if you cannot get out, put on, you know, your favorite artist and dance around your house. And I'm serious about that because we have to keep moving. So those are just a few of the ways that we can use to cope with stress.
All right, we are going to move to the questions from the audience. I'm looking at some really great questions. I'm going to read them cold as best that I can. Okay. How should we interpret doctors prescribing meds that have not been shown through clinical trials to treat COVID, particularly in the context of that driving demand and subsequent shortages? I think they're talking about a couple of those tests that went out, and then next thing you know, people who had lupus and other kind of illnesses could not get the drugs.
So, and you know, what I said and many other doctors said and always say that we have to wait on the science. You know, we hear about something and then we are all anxious to find that treatment, that cure. We know a vaccine is going to take some time. And so I encourage everyone to just breathe. And even when we have good news about a particular medication, that does not mean that everyone should be taken. Now, physicians certainly have the autonomy to prescribe or decide on a treatment course with their patients. That has been the way it's been pre-COVID-19. It is the way it should be during COVID-19 and post. So individual decisions about any medication should be between the patient and the physician. But what we always do, and what I said, is even medications that I prescribe routinely, all medications have side effects, you know, even medications that some folks think are very simple medications. And so what physicians do, what we have done and will continue to do, is talk with our individual patients about the side effects, the common mild ones and the uncommon significant ones, and then the decision to treat or not treat is between the patient and the physician.
All right, here's the next question. What are you looking at or considering when state or federal officials flattening the curve? Is it the deaths or new cases?
All of it. Every data point is critical. And that's important. Any one data point in a silo is often, it lacks context. And so we need all of that. We need the new cases. And let me say this, because I want everyone, I think this has been said. The new cases, if you define a new case as the number of positives, the more we test, the more likely we are to get new cases. That's an important data point. But that also has to be interpreted in the context of the total number of tests. You know, if someone says we have 1,000 tests, that is meaningless in and of itself. 1,000 positives. Is it 1,000 over 1,000 tests? Is it 100%? Or is it, and I'm just using this as an example, or is it 1,000 over 1,000,000 tests? So we need the total number of tests, the total number of positive, hospitalizations, deaths. We need all of that data. And by the way, speaking of data, and particularly regarding the disproportionate impact, the AMA early on called on the federal government to track data by race and ethnicity. It also needs to be tracked by zip code, by gender, looking at language. So we need as many data points as possible to
Yeah,
fully
I think,
interpret. Yes.
yeah, I think the numbers are probably going to continue to soar if we see that, the disproportionate numbers. I think I read something today, maybe 30 states, 33 states or something were finally doing that. But again, not all of them.
And it has to be standardized, but that's into
Yeah,
the
yeah.
weeds, but that's what we've called on because we want to make sure we're comparing apples to apples. You know, people will just throw out a data point, and I always have a lot of questions, right?
Yeah.
And that's why context is important.
This is a long question, but it's a good one. Okay, can we address the mutations of SARS-CoV-2? It appears in non-peer review studies, this is obviously somebody who's in the health profession, there are at least 2 mutations. The Wuhan strain is the original and is milder and came to the West Coast. And I'm reading this question.
No,
folks,
I get, yeah.
Obviously, I'm not saying that any of this is true, and neither is Dr. Harris, but we're reading the question. The European strain is a mutation and is more virulent and came to the East Coast. Which are we testing for with antigens and antibody tests? We have people like Madonna who have tested positive for antibodies, so they think they are safe and they can party without masks because they think they are safe. Can you address the public health implications of people thinking they are safe because of antibody tests, even though we are not testing for all mutations?
So let me take that second. Yes, let me take that second question because that's a very important point. I think early on, and look, we thought, probably many of us hoped, including me, that once you had this disease, and people call it immunity passport, right? You're free and clear. But now we know, of course, remember this is a new coronavirus and we don't know if it's going to behave like other coronaviruses. So I want everyone to know that right now you cannot interpret a positive antibody test as an immunity passport. That's why, and I'll say this again, I said it earlier, if you receive an antibody test, you need to make sure you take that antibody test and call your physician and talk to them and say, I got this antibody test, I got it from this location, is this kind of test, help me interpret it. But I will say right now that we do not know, we do not have the data to support if you get a positive antibody test, let's assume that the test is correct, right? If you get a positive antibody test, that means you're free and clear. So that's very important.
So,
I need to say that. So take that test with you and take it to your physician and help them interpret that test for you. The 2 strains, and we're just hearing about this in the last couple of days, and listen, I don't pretend to be a virologist, but there does appear to be 2 strains. The latest I read was they, at this point, don't appear to be that different, that it would impact the testing, but we still, of course, the scientists and the researchers will still continue to drill down on that issue. But you're right, there is a strain now because we think most of the New York and some on the East Coast maybe came from Europe, and maybe some on the West Coast came from China. So stay tuned to that. That sounds like a person who is following the science and the data. Continue to do that.
So does this mean, and this is something, what is the latest, is it whether you are still contagious, whether you still have the virus and you can spread the virus if you have once been tested positive? Is it something that you should go and get perhaps another test to determine that you're negative and you're good? Or is it just the assumption that you're no longer positive, therefore you are no longer contagious?
So a couple of things, and one thing I want, because we had not made this point tonight, that we originally, and this was something that's new to your first question tonight, our original thinking was that you were contagious when you were showing symptoms, right? And then we learned that some people will be asymptomatic, no symptoms, or what we call pre-symptomatic, which is maybe the period of time before you show symptoms. So that is why some people say, well, I'm not coughing, I'm not sneezing, I don't have or I don't have shortness of breath, so I must not be contagious. Yes, we know that there are people that you can spread this when you're not having symptoms. All the more reason to wear a face covering. So we want to make sure we talk about that. Again, all these tests, once you have been diagnosed, then I encourage everyone to take that information to their doctor and talk about, okay, I'm positive, I had this test. What does this mean for me? By the way, people should be receiving that information when they get tested. I know people are getting tested in many ways, and we are so glad to have many options. We need to make sure testing is available and accessible. But make sure people say, well, what do I do when I get my test results? Talk to your physician about what to do when you get your positive test results.
But is it 3 days after? Is it 2 weeks? Is it 3 weeks? Or how long are you perhaps contagious or not contagious? At what point are you out of the clear, so to speak, and at least you're not contagious?
And the reason I'm saying talk to your doctor, because I heard a story today. Let's say that you were, because remember, tests were not very available, right? So let's say you have been having symptoms for 3 days, and then you went to get the test, right? And maybe I have just been having symptoms for 1 day. So all of that is very important information for you to talk with your doctor when in the course of disease. I learned, I don't even want to say, some folks are testing, counting. You get a test and they say, when did you first have symptoms? And if you said 5 days ago, they are going back to that
14 days from that.
Yes.
Yeah.
I'm saying they're going back to that date to even count the day that you were positive. So I just can't say enough. I realize people want sort of blanket, but that's not helpful.
Yeah. Once again, there's no clear answer. It just keeps happening.
And there's no one size fits all. There's no one size fits all answer. Okay. We can talk about ranges, but if I don't want anyone, people take an answer and say, oh, it's 7 days. It's 7 days for me. So I really respect individual differences and the fact that we need to interpret all these tests within the context of overall health.
Speaking of tests, here's another. The deaths of Blacks are disproportionately high. Testing has been proven to be the best tool to flatten the curve and stop the spread, but testing has not scaled up to the levels necessary to be immediately effective. What can we do to increase testing, especially in Black communities? Should the Black churches' public spaces be used for on-site testing of Blacks? I know that was a huge issue in Chicago, and they keep opening places, and I see the news reports across the country.
Let me clarify one quick thing. Testing is not the best tool to flatten the curve. The best tool to flatten the curve is staying at home, sheltering in place, wearing a face covering, washing your hand, and not going out in large gatherings, right? But again, we have to think, so that's the best tool we have at this moment. But we have to think about the fact that the more things we do, the better we will be able to flatten the curve. So testing is a component of that. But I want to say the best tool is sheltering in place and staying safer at home. Here's how testing helps. And here's how it's important to test a particular zip code. Because if you find a large proportion of positives in that zip code, you can zero in on that zip code and see what folks in that zip code need and make sure they are getting the follow-up care that they need. So testing is very important. Getting the tests, getting your results interpreted. If you have to isolate or quarantine, having support to be able to do that. So it's like layers, and the more we do, the more we can minimize the spread.
And let me point out something. You say, talk to your physician, talk to your physician. I literally just finally got to know my physician about a year or so ago and back and forth. And there are many people, quite honestly, who, you know, when something comes up, they go to the doctor, they don't have a physician. So what are they supposed to do? I mean, they're looking for answers. They got the results of the test and whatever. And right now, of course, there's nowhere in the world you're going to get a physician because, you know, because you can barely get an appointment for a doctor's visit. So you're not going to be able to establish a physician. What are people supposed to do? Because again, in this society, so many people don't have
a physician
to call.
And that is true, and that's one of those issues around the differences in the disproportionate impact, and I agree with that, and thank you for that. That's a very important point. And so here's one thing I recommend. Every state, at least I'm familiar of, and even down to the county health departments, have an information line. So if you don't have a physician, contact your local public health department or state. Everyone that I am aware of has a 1-800 information line for those who have questions and don't have a physician.
Okay. Are there sources to track where tests are available and how easily they are to access? Yeah.
Oh, and this is a good question because you asked me. I absolutely believe we need to have tests where people live, right? Now, early on, and I think everyone knows, we did not have enough tests. We still do not have enough tests. And again, the whole testing capacity and strategy. But I do know that public health departments are trying to get testing to communities. Ministers can volunteer. There are parking lots, churches, any local institutions or community-based institutions should, and I recommend, offer your parking lot as a testing site. And the point of contact is the state or local public health department.
So what's the name of the drug that's now being that's now being used to treat remdesivir?
Remdesivir, yes, okay. Yes.
There's a question here that says, where is it being distributed? And are hospitals with large numbers of Black and brown patients getting access to that medication?
So remdesivir is in clinical trials. I have to say, I don't know all of the locations. If you go to clinical, and we could have a whole other conversation about African Americans and clinical trials, which we should have at another time. That's very complicated and nuanced, as most of these issues are. But I believe if you go to clinicaltrials.gov, you should be able to know where clinical trials are. Remdesivir is a medication that is given IV through the vein, so it's not like you could pick this up at your pharmacy. Clinical trials are going on as we speak. Early studies, early results thus far show that it may have some positive effect on limiting the duration of hospital stays. So listen, we're already thinking if you're in the hospital, right, you are having a severe course. But that's progress, but that's where we are right now.
So how close are we?
Very early. It's very, very early
months,
in clinical
weeks?
Trials. It depends on, let me just say, it depends on the results. There have been clinical trials of other medications that have been stopped early because the success was so great, right? So we just cannot predict how long it will take for this to clear through all the clinical trials.
The vaccine, same thing kind of with the tests. There are a number of different research labs, universities working on a vaccine all around the world. What's the latest and who's the closest? And give me some good news.
So Dr. Fauci, who is a renowned expert, originally, let me just say, vaccine trials take a while. Dr. Fauci's early estimate was 12 to 18 months. Sometimes it takes longer. We are still working on a vaccine for HIV. So I think we all need to be realistic. Now, in the last couple of weeks, first of all, the good news is everyone, or not everyone, but multiple folks are working on both treatments and vaccine. So a lot of studies are happening in parallel. that is a good thing. And they're working on different mechanisms of action in both a vaccine and a treatment. That is also a good thing. So the good news is that may shorten the time, all right, from the normal course of time. So that is the good news, although I don't want to be overly optimistic. But, when you have more than one group of folks working on any one thing, you might see progress quicker. So that is the good news. We've heard over the last week or so that some folks are saying maybe by January, but I think you heard both Dr. Fauci and Dr. Birx both say that everything will have to go right for something that soon. That's ambitious, that's optimistic. We will just have to wait and see, because we absolutely want it to work, right? We want it to be effective, we want it to have efficacy, but we also want it to be safe.
Yeah.
And you don't want to sacrifice efficacy or safety for speed, right? So you have to balance that. So I think we will just have to wait and let the work and the science happen to make sure that a vaccine is, and treatment, but this goes for both, are both effective and safe.
So this is speculation that I'm asking you, but when there is a vaccine, do you think it will be required in, well, probably all children? How do you think it will be rolled out? How do you think we will eventually have to be able to get this vaccine? We'll be standing in long lines, because I feel like we'll be standing in long lines trying to get the vaccine.
Well, certainly that does remain to be seen. I think we should all, those of us, I will say, and who advocate for effective treatments, we will want vaccines to be equitably available. We will want treatments to be equitably available. So I can tell you from the standpoint of the American Medical Association, that will be our focus of advocacy, making sure that whatever vaccine comes forth or whatever treatment comes forth, it is equitably available. Now, I would say there might be, and I'm just, and this is even speculating, and we could have I think, a fair-minded conversation about this, but if a particular population is vulnerable, one, I believe, might make a fair-minded argument that they might be first in line. But again, that is something that we should, of course, have fair-minded, evidence-based debate and thoughtful decision-making on something like that, who should go first. It does make sense to me that those who may be more impacted or in a higher risk category, if there isn't enough for everybody to get it at once. And of course, even if they made enough for everyone to get it at once, there would be logistics, as you stated earlier.
I just want to let our audience know that some of the questions are kind of similar. So, I'm trying to get to as many of them as I can, but just also make sure they're varied. Here's another one. Beyond testing, contact tracing, and collecting data, what are the most important things states should be doing to protect minority populations, not only from the disease, but also from negative economic and other impacts as they look to reopen the economy?
So one of the things we have to look at, and we talked about the fact that communities of color, African Americans, are in a higher proportion in some of these front-level jobs. And we heard today, or at least I heard reports of folks who are making choices between going to work and keeping their families safe.
Yeah.
So we should continue to have conversations around sick leave, right? And again, I talked about supported quarantine and isolation. Again, if you test positive, if you are an essential worker and you test positive, but you live at home with folks a grandmother who has diabetes, you don't want to come home. And so, hopefully local jurisdictions can think creatively about where we can offer places for folks to quarantine and isolate, unused hotel rooms. I got a call here locally about a university is having unused dorm rooms, right? Students are not there, they are at home. Other things are making sure, and this is a little bit tangential, but I talked about equitable opportunities. Children are distance learning, right, but may not have computers at home. And so I know school systems and have already done this about nutritious meals and making sure they support families through e-learning and making sure they have computers and laptops. I saw a report of a community who used their buses and parked their buses in communities where a lot of students live, but maybe didn't have Wi-Fi. Those are, little things like that. And so Wi-Fi, these buses then served as Wi-Fi for those communities, and students could do their distance learning. And these are things, again, this is why it takes partnerships. Of course, one of the issues that I've been worried about is intimate partner violence and domestic abuse increasing during this time. And I just read, of course won't name any particular company, but a company is offering free moving for someone who's been a victim is a victim of intimate partner violence and needs to move. So these are just things that we probably don't think about at the surface, but we have to think about and make sure folks are supported.
Are the issues different in Black and Brown communities in terms of mental health and in terms of some of the incidents that we're seeing?
No, I have not seen any studies that there is a difference. I guess pre-existing differences that I've been talking about are there's such a stigma. So there's a stigma overall, right? And there appears to be, this is getting better, but still not where we need to be, but a stigma around getting help. I did a town hall for women, my sorority, a couple of nights ago, and there's the myth of the strong Black woman, and sometimes people internalize that myth to mean that we can't ask for help. I've seen so many of my patients who, once I treated them for depression, this has happened more than once, they said, they didn't know a life other than the life they were living. They had almost accepted being clinically depressed as normal, if you will, typical. I don't even like to use the term normal. So no differences, right, except for some of the external differences regarding stigma, help seeking, and then of course access to health care. There's no question that so many more African Americans were able to access care, mental health care, care for substance use disorders with the expansion of Medicaid.
All right, we're going to wrap up in a second, but I just want to take a couple of quick questions. Once you're infected, home remedies like zinc, echinacea, lessen the effects or stamp it out altogether?
No evidence to support any home remedies to stamp out COVID-19.
Okay. How long do you believe physical distancing will last? Will this be the new normal until a vaccine is found? Probably.
I don't know if it will be the new normal until a vaccine is found, but there will be some aspects of that. I think face coverings, here's one thing we have to figure out, and I think we should figure out this together. We're very used to shaking hands. And it almost feels awkward, not now in the midst of the pandemic, but I have a feeling that at one point we'll feel awkward not shake. So how do we acknowledge? We'll have to, I think, figure out a new normal for, I'm thinking of maybe putting my hand over my heart, but, so I think there will be some new customs and some new traditions. We will have to physically separate, and it will depend on the virus, and I think it will depend on, with the course of the virus, and we will learn this as we get further along.
Yeah, I think we're going to see some huge changes when we return to our offices. I saw a report the other day, they're putting up the plastic dividers and such, all those little cubby holes will now, have plastic dividers between them. There's going to be a lot of changes. Some closing words here, because we're coming up on 6:30 or 7:30 Eastern time, 6:30 Central time. Some closing words as we wrap this up.
Well, first of all, again, thank you, thank you, thank you on behalf of the American Medical Association for the partnership and for us having a conversation. You know, as a psychiatrist, and I'm not, I don't shy away from difficult conversations. I'm not saying, and these are the difficult conversations we are going to have, the new normal. What are we going to do to address health inequities? What are we going to do to address access to health care? How are we going to manage, you know, a month from now, 6 months from now, a year from now? I do believe, and to end on an optimistic point, and you asked to give hope, I do believe that if we are all willing to come to the table, educated and with facts and the evidence, and willing to listen to one another and come together. We don't need to argue about either or. I think we spend so much time arguing about either or, but just making sure we are working together to develop solutions. I think there's progress. We certainly, I am obviously, or maybe not obviously, I'm African American, and I feel a particular obligation and responsibility, you know, as the first African American woman president of the AMA to, and the AMA feels this as well, to continue to lead on addressing these issues. And I hope I can count on, I know I can count on NABJ, but we will
Oh,
be looking
absolutely.
for other partners to help us lead this conversation and the many conversations that we have to have going forward.
Well, you know, thank you for answering all of our questions and really kind of giving some insight into the testing and the data and, you know, the various vaccines and drugs and explaining all of that. I mean, it was really great information, clearing up some misinformation and such. And I really appreciate it. And I'm sure our listeners do and our viewers as well. So again, Dr. Patrice Harris, President of the American Medical Association, the first African-American woman. Appreciate you joining us. To our audience, thank you for participating in the town hall. You guys asked some really fabulous questions. I know I didn't get to all of them, but you know, as Dr. Harris said, you know, please keep asking your questions and we'll get through this together. All right, thank you.
Thank you. Take care. Stay safe, everyone, and stay home.